Hi everyone, welcome back to Next Level of Ophthalmology. We are starting a new chapter today, Orbit. So I would like to start this chapter by paying respects to Dr. Santosh Hanawar, the doyen of Orbit and Oculoplasty. Today we'll be dealing only with anatomy and the developmental anomalies of the orbit. So let's start with anatomy. Orbit is a pyramidal shaped structure. They are two in number and they are placed parallel to each other. So it's like a square based pyramid with its apex pointing towards the brain. So if you see the medial walls of the orbit, they are parallel to each other, whereas the lateral walls, they are at a angle of 90 degrees. Okay. So let's start with the walls of the orbit. The orbit is made up of 7 walls, and I've made a small mnemonic for you to remember. The bones that are making up the orbit are frontal bone, ethmoid bone, maxilla, palatine, sphenoid bone, lacrimal, and the zygomatic bone. Okay, so let's start with the base of the orbit. The base of the orbit is open anteriorly and is bounded by orbital margins. So we have these orbital margins are also known as the orbital rim. So we can calculate the orbital index by taking the height of the orbital base and the width of the orbital base and dividing it by 100. So we get something known as an orbital index based on which we can classify them into megaseam, mesoseam and microseam. So these are specific indices for different races like I have written here. So let's start with the medial wall. Medial wall is quadrilateral in shape and it is formed by the frontal process of the maxilla here, the lacrimal bone, the orbital plate of the ethmoid bone, and the body of sphenoid. So this is what makes up the medial wall of the orbit. The medial wall is extremely thin and it's usually fractured during orbital injuries and orbital surgeries. Also, ethmoidal sinusitis is the most common cause of orbital cellulitis because this wall is very easy to breach. The anterior-most part of the medial wall bears the lacrimal fossa, which houses the lacrimal sac. The orbital floor is formed by the orbital portion of the maxillary bone and the zygomatic bone. This is the maxillary bone and this is the zygomatic bone, and posteriorly by the palatine bone. So orbital floor has a deficiency called the inferior orbital fissure, which houses the inferior orbital nerve. So presence of this fissure up to posterior half of the orbital floor makes it a little weak and vulnerable to damage during fractures. So this is another common site of blowout fractures. Tumors of maxillary sinus can easily invade the orbit through this deficiency. Coming to the lateral wall, it separates the orbit from the middle cranial fossa and the temporal fossa, and it's the thickest wall of the orbit. It is formed by the orbital portion of the maxillary bone, orbital portion of the zygomatic bone, the greater wing of sphenoid, and partly by the frontal bone. The palpation of retrobulbar tumors is easier through this wall because this wall is not very wide. It stops short compared to other walls. It's also uh, and this is the reason why the lateral portion of the globe is more susceptible to injuries. Lateral orbitotomy is a common approach in orbital lesions. Coming to the roof of the orbit, it's formed by the orbital plate of the frontal bone and the lesser wing of sphenoid. So this is the lesser wing of sphenoid here, and this is the orbital plate of the frontal bone. So through the orbital roof, the orbit communicates through the anterior cranial fossa, and injury in this area can easily damage the anterior cranial fossa contents. Coming to optic foramina, these are the communications between the orbit and the cranial cavity. So these are superior orbital fissure, inferior orbital fissure, anterior ethmoidal and posterior ethmoidal canal, and optic canal. Infections like panophthalmitis, mucormycosis can easily spread to the intracranial cavity through these foramina. So we have already learned this in neuroophthalmology. This is a short recap here. So what is orbital apex? Orbital apex is superior orbital fissure plus optic canal. So optic canal has the optic nerve and the ophthalmic artery. Superior orbital fissure is also known as the sphenoidal fissure and is present between the greater and the lesser wing of sphenoid. It has LFT, okay, lacrimal nerve, frontal nerve, and trochlear nerve, along with the superior ophthalmic vein. So the superior orbital fissure is divided into two portions by the common tendinous ring. The upper portion contains LFT, whereas the lower portion contains abducens nerve A, N, and O. That is abducens nerve, mesociliary nerve, inferior division of the oculomotor nerve, okay, and the superior division of the oculomotor nerve. And inferior to this common tendinous ring, you have the inferior ophthalmic vein. So this lower portion is the inferior orbital fissure, which houses the infraorbital nerve, zygomatic nerve, and infraorbital vessels. So what is orbital apex syndrome? This is total ophthalmoplegia with visual loss and loss of corneal reflex. We have discussed this in neuro-ophthalmology. However, if you want to learn again, so this orbital fissure will have the fourth nerve, the sixth nerve, and the third nerve as well. So this leads to loss of all the motility of the eyeball along with loss of corneal sensation because the frontal and the lacrimal nerves, the parts of the ophthalmic nerve is also involved. Now coming to superior orbital fissure syndrome, there is no involvement of the optic canal, as a result of which there is only total ophthalmoplegia and loss of corneal reflex. Applied aspects of this are the medial rectus is in close association with the optic nerve sheath. Okay, so in optic neuritis, the ocular movements become painful. Let's take a question now. Which of the walls of the orbit is thinnest? We have already discussed this. The medial wall. Medial wall is the thinnest portion of the orbit. The structure located between the greater wing of sphenoid and the lesser wing of sphenoid is the superior orbital fissure. Supraorbital notch transmits the supraorbital vessels. It's present in the orbital rim, and the supratrochlear notch is somewhere here, just medial to the supraorbital notch. The superior ophthalmic vein is well within the orbit and it runs parallel to the medial wall of the orbit. Okay. The Whitnall's tubercle gives attachment to the following structures except lateral check ligament of the lateral rectus, lateral palpebral ligament, anterior lacrimal crest, and suspensory ligament of the eyeballs. The answer here is lacrimal crest. So what is this Whitnall's tubercle? It's an important landmark in the lateral wall of orbit. It's a small elevation that is seen in the lateral wall of orbit. Okay, it gives attachments to 5 L's: levator aponeurosis, lateral rectus check ligament, Lockwood's suspensory ligament of the eye, lateral canthal tendon, and lacrimal gland fascia. I hope it's clear. Match the following structures that pass through their respective orbital foramina. Okay, so what is a sphenoidal fissure? I told you it's also known as the superior orbital fissure. So what does the superior orbital fissure transmit? LFT. So we have lacrimal nerve here. So A is 2. Optic canal, okay, we know that it transmits the ophthalmic artery and which continues as the central retinal artery along with the optic nerve. Then the inferior orbital fissure, it transmits the infraorbital nerves, and anterior ethmoidal canal, it transmits the anterior ethmoidal nerves. So let's see which of your options is right here. A2, B4, yeah, I think this. So B is the answer here. A2, B4, C1, C1, D3. All right. So we have the right answer here. And yeah, let's move on to the fascia of orbit. There are three important fascia that I want you to understand. First is the periorbita. It's also, it refers to the periosteum of the orbit. It's loosely attached to the orbit except at the orbital margins and the optic foramina. Why do you need this information? When you're doing orbital surgeries, when you're raising the periosteum to reach some tumors or when you're doing an excentation, it's a little difficult to raise the periorbita near the orbital margins. Okay. Orbital fascia, this is the thin connective tissue that lines various orbital structures. Examples are extraocular muscles, suspensory ligament of Lockwood, Whitnall's ligament, and orbital septum. So these are lined by the orbital fascia. The third one is fascia bulbi or the Tenon's capsule, which is closely adherent to the globe from the limbus till the entrance of the optic nerve. So let's learn various spaces of orbit. Some people call orbit as Pandora's box. Okay, because we get many types of lesions in the orbit, inflammatory, degenerative, tumors, malignancies, henceforth, vascular lesions. So let's learn the spaces of orbit. The first one is the subperiosteal space. It is a potential space present between the bone and the periorbita. Okay, so abscess in this space is visible on CT scan as a convex elevation, something like your extradural hematoma. When there is an abscess or a hemorrhage in the subperiosteal space, you can see it as a convex elevation as space is tightly bound by the periorbita. The next is the peripheral space. So this is the space between the extraocular muscles. Okay, imagine the orbit. This is from you're seeing from the center. I mean the anteriorly. This is the eyeball, and these are the four extraocular muscles. All right. So there are septa which connect this. Okay, so this is created into a space. So the space outside this is known as the peripheral space. So if there are some tumors or masses in this, they produce eccentric proptosis and they can be easily palpated. And for when you give peribulbar block for your surgeries, the injection is delivered in this space. Okay. So what is central space? Again, let's do the drawing. Orbit, eyeball or the globe, the four recti and the connecting intermuscular septa. So this space within is known as the central space. So it is a very small space. It's also called as the muscular cone. So towards posteriorly it becomes a cone. Okay. So anteriorly it is open like a ice cream cone. So it's bounded anteriorly by the Tenon's capsule lining back of the eyeball. So if you see it laterally, there is Tenon's capsule here lining the back of the eyeball, and peripherally the four recti muscles with their respective intermuscular septa. So this becomes a very small space. Okay. The tumors lying here or any masses in this area will push the eyeball forward and cause axial proptosis. And since the space is very restricted, this space has the optic nerve in the center. So because the space here is very less, any raise in the pressure can cause optic nerve damage very soon. And here retrobulbar injections are given in this space. Okay. The next is the Tenon's space, which is a potential space between the eyeball and the Tenon's capsule. Subtenon injections are given in this space. Let's take a question now. Injection of a local anesthetic before cataract surgery caused complete ptosis, loss of extraocular motility, except intorsion, and there is pupillary dilatation. So we have ptosis, which is responsible for, third nerve is responsible for lid, loss of all extraocular muscles. So third and sixth, except fourth. So they're saying there is no involvement of the fourth muscle because intorsion is still there. So fourth nerve is not active. Fourth nerve is not affected, and there is pupillary dilatation, which means there is third nerve involvement. So, what space do you think the injection was given? So, to understand this, you understand that all these nerves, third and the sixth and the fifth, are within the central space, except fourth, which travels from the peripheral space and then enters the supplies the superior oblique. So, the fourth nerve is always outside the central space. So, because the fourth nerve is spared here, the injection was given in the central space. I hope it's clear. Increase in the pressure in which surgical space is detrimental to the functioning of optic nerve. So, I already discussed this. This is the central space or the retrobulbar space where the optic nerve is present within the space. Okay. Let's come to developmental anomalies of the orbit. So this is closely related to development of the skull because the skull houses the orbits. Okay, so there are um, multiple sutures that you need to know. The coronal suture is the one that is parallel to the that's perpendicular to the anteroposterior axis. Sagittal suture is parallel to the anteroposterior axis. So these two sutures are very important for us because the eyeball is and the orbit is somewhere here. So what is craniosynostosis? It is premature closure of one or more cranial sutures. So either coronal, sagittal or frontal or a combination. So what happens when this coronal suture here fuses very early? Okay, so the AP diameter is shortened. So this is known as brachycephaly. The head is short. Okay, so this is characterized by short AP diameter. What is scaphocephaly? When the sagittal suture fuses early, the the uh, the skull becomes boat shaped. So this is known as scaphocephaly. Okay, when the frontal suture fuses very early, you get an egg shaped head, and that is called as trigonocephaly. So when all sutures fuse early, you get acrocephaly. So there are two important syndromes here with respect to the orbit. The first one is Cruzon syndrome. Okay, Cruzon syndrome is an autosomal dominant condition characterized by craniosynostosis, characterized by a short AP diameter of the skull, also known as brachycephaly. Okay, shallow orbits and maxillary hypoplasia. Because the orbits are shallow, the eyeballs look very prominent like you see here, and this is known as pseudoproptosis. They usually have hypertelorism and V pattern exotropia. And unfortunately, these children may develop optic atrophy due to compression of the optic nerve at the optic canal. So other features can be ectopia lentis, cataract, goof thalmos, mental retardation, high arched palate, and irregular dentition. So the next syndrome we are dealing with is Apert syndrome. Okay, Apert syndrome is also a type of craniosynostosis. It is characterized by pseudoproptosis, anti-mongoloid slant, and a high arched palate. Lid coloboma is not a part of Apert syndrome. It is usually seen in Treacher-Collin syndrome. Okay, so what is Apert syndrome? If you see, the skull is very elongated. It's a tower-shaped skull. It's also known as acrocephaly syndactyly syndrome. The skull is elongated vertically. It's a severe form of craniosynostosis in which all sutures may be involved. The systemic features include mental retardation, tardicephaly or tower-shaped skull with a flat occiput, high-arched palate, syndactyly of fingers and toes. So, ocular features may include hypertelorism, exotropia, shallow orbits with pseudoproptosis, anti-mongoloid slant, and congenital ptosis. So these are the associations that you get in Apert's syndrome. So that's all for today. So I would like to advertise my two books that I have written. One for undergraduates, competency-based questions and answers in ophthalmology, and the other one is Clinical Manual of Ophthalmology, which helps postgraduates deal with their clinical every day-to-day clinics. Okay, thank you. We'll meet next week with the further continuation of orbit.